Hello, welcome to sonography-radiology training channel. This series of videos is about fetal genitalia ultrasound. This is the first video in this video series with title of Disorders of Sexual Development Part 2. In video part 1, a brief introduction to prenatal diagnosis of disorders of sexual development was explained. In this video, we will review a stepwise approach to disorders of sexual development together. This stepwise approach includes step 1 to describe genital abnormalities. In step 2, we must determine that the DSD is isolated or non-isolated. In step 3, we must record all findings in pregnancy history, and in step 4 we need a complete family history. In step 5 we must request all laboratory investigations which are required, and in step 6 we must complete our information and present differential diagnosis. At first, in step 1 describing genital abnormalities. As I explained in video part 1, it's important to assess fetal DSD in a stepwise fashion to obtain as much information as possible and make the most likely diagnosis in order to enable the woman to make an informed decision regarding the outcome of the pregnancy. Fetal gender abnormality can be diagnosed by fetal ultrasound and/or MRI examination from around 13 to 14 weeks gestation once development of the fetal external genitalia is complete. They may also be noted when there is a discrepancy between the fetal phenotypic detected by ultrasound examination and chromosomal sex detected by craniogenital sampling or amniocentesis. Incomplete masculinization of the external genitalia will be suspected prenatally if the fetal ultrasound or MRI examination shows abnormal phallic structure, means absent short or abnormal shape, and or scrotum, means absent or bifid with absence of undescended testes later in the pregnancy. In this fetus we can see a micropenis with absent scrotum at 15 weeks of gestation. At 25 weeks of gestation we can see here a scrotum without any descended testes, famous as empty scrotum. Also, it may be a discordance between the assessment of the external fetal gender and internal fetal gender by assessment of the pelvic organs and the distance between the anterior wall of the rectum and the posterior wall of the bladder, famous as rectovesical distance, which it was completely explained in video Fetal Sex Determination Part 2. Masculinization of female external genitalia will be suspected when the fetal ultrasound or MRI showed an enlarged phallic structure and abnormal or fused labia instead of a scrotum, with identifiable uterus or a relatively large rectovesical distance. This fetus is a case of prenatal diagnosis of labial fusion. We can see here a perineal well-defined cystic image protruding through the surface of the external genitalia. 3D image shows an eccentric mass outside the surface of the fetus. This anatomopathological image revealed that this is a female genitalia with fused labia and enlarged mass corresponding to urinoma due to the obstruction of the urethral meatus. In step 2, we must determine that DSD is isolated or non-isolated. Once fetal genital abnormalities have been identified, it's important to look for other fetal abnormalities to determine whether the genital abnormality is isolated or not. When genital abnormalities are associated with other non-genital detectable abnormalities, they are more likely to be the result of chromosomal abnormalities, single gene disorders, or teratogen exposure. However, since fetal ultrasound does not detect all fetal abnormalities, what is thought prenatally to be an isolated genital abnormality abnormality may turn out postnatally to be associated with other abnormalities. In step 3, we need a complete pregnancy history. The pregnancy history should include information regarding maternal diseases resulting in virilization like hirsutis, excessive cystic acne, and enlarged clitoris due to maternal androgen-producing tumors or placental aromatase deficiency. Also, we must evaluate maternal exposure to androgen endocrine disruptors or teratogens. The results of the screening for Down syndrome should be reviewed to check whether the maternal serum unconjugated sterol level is low, which is typical in fetal conditions such as Smith-Lemli-Opitz syndrome, congenital adrenal hyperplasia, placental aromatase deficiency, and also trisomy 18. Furthermore, high alpha-fetoprotein and human chorionic gonadotropin and low pregnancy-associated plasma protein A levels or PAPA levels may indicate placental insufficiency, known to be associated with a higher incidence of hypospadias in male fetuses. In step 4, we need a complete family history. A 3-generation family history using standardized pedigree symbols should be obtained. Information regarding family members with genital or other abnormalities, recurrent miscarriage, stillbirths, mental retardation, and inherited conditions should be obtained. A family history of consanguinity can suggest recessive disorders such as congenital adrenal hyperplasia, disorders of androgen biosynthesis, and Fraser syndrome. It also increases the risk for multifactorial conditions such as hypospadias. A family history of childless or amenorrheic females points toward the possibility of androgen insensitivity, and unexplained infant death raises the possibility of salt-losing congenital adrenal hyperplasia. Similar abnormalities in SIPs or other family members should be taken into consideration when the fetal ultrasound examination and other investigations are being done looking for recurrence. In step 5, we must request all laboratory investigations which are required. The initial investigation of fetal genital abnormalities should include chromosome analysis as well as microarray analysis if indicated. According to the fetal ultrasound findings, the amniotic fluid can be checked for additional hormones including 17-hydroxyprogesterone and other specific hormones. Mutation analysis for specific conditions based on the family history and/or the fetal ultrasound findings can be done using fetal DNA for conditions such as 21-hydroxylase deficiency, 5-alpha reductase deficiency, and SRY mutation. However, mutation analysis is a lengthy procedure when no specific mutation is analyzed based on family history, and the results may only be available late in the pregnancy or after delivery. In step 6, we must complete our information and present our differential diagnosis. Non-isolated DST indicates the possibility of maternal exposure to teratogens, fetal chromosome abnormalities, and single-gene disorders, or may indicate sporadic conditions such as cloacal dysgenesis and omphalocele extrophy of the bladder, imperforated anus, spine abnormality, or OEIS syndrome. Most cases with DST detected prenatally have isolated genital abnormalities, and since the same phenotype can result from various conditions, further investigation in the form of amniocentesis for chromosome analysis and amniotic fluid hormonal studies should be offered to the woman if she wishes to obtain precise information regarding the etiology and thus the prognosis. Now, I suggest 2 others of my videos that are close to this video in terms of matter. And thank you for your attention.